primary amenorrhea is a common clinical problem in gynecology. However, when clinicians are confronted with unexplained pelvic masses, it's difficult to associate with primary amenorrhea. So, is it just a coincidence? Today, our case report will tell you the answer. I'm Zhou Jiahong, a laboratory physician of Southwest Medical University Affiliated Hospital. The title of the case I'm sharing is Karyotype Analysis, Unraveling the Mystery of Gonadal Tumor Hidden Etiology. Let's start with the patient's medical history. A 17-year-old girl, not yet menstruating, was admitted to the hospital with the chief complaint of severe abdominal pain induced by physical exercise. What's wrong with this girl? Further physical examination showed that the patient was 146 cm in height and weighed 16 kg. Notable, bilateral breast not yet developed, and vulva development was normal. Congenital head was bulging. What concerns doctors most is about 10 cm mass in the pelvis with clear borders, inactive, and obvious pressure pain. It's easily associated with pelvic tumors. Further lab analysis showed a significant increase in neutrophil-based white blood cells. Tumor marker AFP and hormone beta-HCG is sharply increased, while the hormone E2 and AMH levels were significantly lower than normal. What's more, the ultrasound indicates infantile uterus. A cystic dark area was observed in the right adnexal region, while no abnormality was found in the left adnexa. Taken together, a combination of physical examination, laboratory, and imaging findings, gynecological tumor was considered. Thus, a laparoscopic exploratory surgery and right ovary and fallopian tube resection was performed. As expected, the surgery revealed an infantile uterus, an enlarged right ovary with cystic solid mass containing multiple cystic cavities, while no abnormalities in the left ovary and fallopian tube. Further pathological and immunohistochemical analysis supported stage IC2 of right ovary dysgeminoma. So, do you think it's the end? Of course not. Attention all, primary amenorrhea, short stature, delayed secondary sexual characteristics, and sex hormone disorders. All the above information also suggests that genetic factors may be involved in the pathogenesis. So, we had our first communication suggesting the need for the patient to undergo karyotyping. Exactly, the patient's peripheral blood karyotype was 14-5X 14-6SY mosaic C. We further performed Y chromosome microdeletions and SRY gene analysis. All the regions of AZF, A2C, and SRY gene were detected, and no variants were found in the promoter and the coding region of SRY gene. Given the patient's 14-5X 14-6SY mosaic C karyotype, clinical presentation consistent with Turner syndrome, the patient is at high risk of ovarian tumor recurrence. So, prophylactic seeing of the left ovary is recommended. Therefore, the left gonadectomy was performed in between chemotherapy sessions after MGT discussions. Finally, the histochemical results supported left ovarian gonadoblastima. Taken together, the diagnosis of this patient was considered to be 14-5X 14-6SY Turner syndrome with dysgeminoma and gonadoblastima. Through this case, we found that pelvic masses and primary amenorrhea are more than just a coincidence. Preoperative karyotype analysis is clinically crucial for young patients who present with both primary malaria and pelvic masses, as it's likely that abnormal gonadal development due to genetic level may lead to primary malaria and gonadal tumor. And if symptoms such as delayed puberty and primary malaria occur, hormone levels should be tested and karyotype analysis should be performed as early as possible for early diagnosis, treatment, and prevention of gonadal tumor. Okay, that's all my presentation. Thanks for your attention.